Well, thank you all again for joining us. I know that lunch break was brief, but we are glad that you've returned to hear more of what we have to share. So again, my name is Dr. Lori Vick. I'm a professor at the University of South Carolina in Columbia. I'm a professor of nursing, and I have with me today, as a part of our panel discussion, a group of students who were in class with me. And they just completed this work last semester. And I'm going to ask each one of them to share a little bit about themselves, and then we'll get right into the discussion. So let me start out with Miss Asia Sumter. Will you please introduce yourself?
Yes, ma'am. Thank you, Dr. Vick. My name is Asia Sumter, and I am from Sumter, South Carolina. I am in my 4th to 5th semester at the University of South Carolina as a graduate nursing student. And following graduation, I plan to be a cosmetic or psych nurse. And thank you guys for having us.
Wonderful, wonderful. All right, Miss Chelsea.
Hi, my name is Chelsea Calloway, and I am also in my 4th semester out of 5 of graduate nursing school at the University of South Carolina. I am from Washington, D.C., and I plan to go into women's health, specifically postpartum, once I graduate.
Wonderful. Miss Fran.
Hello, my name is Frenisha Davis, and I'm from Brevard, North Carolina. I'm a graduate nursing student at the University of South Carolina. I will be graduating in July of this year, and I'm excited to practice as a nurse as I am committed to Black wellness and decreasing healthcare disparities.
Wonderful, wonderful. Miss Cara.
Hi, my name is Kara Walker. I am from Cincinnati, Ohio, and I am also my 4th year here at the University of South Carolina in their graduate nursing program. Following graduation, I plan on practicing in the field of oncology or in the ICU.
Wonderful, wonderful. So thank you all for introducing yourselves, and also really thank you for the work that you've done and your willingness to come here and share this information. So if we could have the first slide up so that we could spotlight what the topic is for our discussion. So the topic is addressing mental health, misdiagnosis in Blacks, and overview and a panel discussion. And you can see that the students are the authors of this work. As I shared with you this past semester, they were given an assignment where they were to develop some scholarship, and they chose this topic, and it is significantly meaningful, I think, to our audience here today, but also it was a wonderful way for us to be able to introduce the experience of Black people to their classmates, to the people here at this university. I think first and foremost, that was really important for us to have that information to share. And then we know that it needs to be more widely disseminated. So I'm grateful for the work that they have done. It's a multi-leveled and layered project that they are doing. And we're just going to go ahead and get into the information that they gathered and what they found out, because I think that's what you really want to hear. So I'm going to start out with asking Ms. Fran, what interested you as a group and as an individual in this topic?
Dr. Vick, before Ms. Fran starts to answer her question, may we go to the next slide, please? Thank you so much.
Well, Dr. Vick, during our clinical rotations, we noticed multiple factors that prevented Black patients from receiving the best care possible, which ultimately affected their healthcare outcomes. In this case, we are referencing explicit healthcare disparities, provider bias, stigmatizations, poor patient education, and institutionalized racism. Those factors cause increased hospital admissions and exacerbations of chronic illnesses that could have been managed at a primary care office. So that leaves us with an inquiry. What happens to Black patients who have a chronic illness and a mental health diagnosis, excuse me? We utilize research to help us answer these questions.
Thank you very much.
Next slide, please.
Okay, Miss Kara, please share with us what your findings were.
So as part of our classwork, we were asked to complete a comprehensive literature review in which the articles were required to come from a nursing journal. And we were able to pick any topic for our literature review as long as it was tied back into mental health. As we have stated earlier, we chose to focus our literature review on the misdiagnosis of Blacks with schizophrenia. And this idea came about after we spent some time at various psychiatric units within the state of South Carolina and noticed that the majority of the Black patients had a schizophrenia diagnosis. We were unsure if this was a mere coincidence and decided to look into this subject further. Now, after using the parameters outlined for us, we only found 3 research articles within the past 5 years that discuss the misdiagnosis of Blacks with schizophrenia. And with Dr. Vick's permission, we were able to expand our search to PubMed and other research journals and found 82 articles published from 1974 to present day. For our project, we were only required to investigate 4 articles, which I'm about to touch on. And I would just like you to look at this timeline that's on your screen. This timeline outlines findings that have contributed to the misdiagnosis of Blacks throughout the decades. And before we jump into this timeline, I just wanted to briefly talk about schizophrenia and the gold standard of treatment for this disorder. So schizophrenia is a mental health disorder that is characterized by a combination of hallucinations, delusions, and disordered behaviors that impairs an individual's daily ability to function. And prior to the invention of drug therapy for this disorder, individuals with schizophrenia used to get castrated to prevent them from reproducing. And they were also undergoing a very aggressive form of ECT, otherwise known as electroconvulsive therapy. Now, just imagine going through all of this traumatizing treatment for a disorder that you may not even have. So this brings me to the 1950s when the first generation of antipsychotic medications were developed. And while this was a huge milestone, there were some consequences and side effects that came along with these medications. And one of these side effects is tardive dyskinesia, which is the involuntary oral buccal movements of your face. And after taking these medications, some individuals were left with this side effect for the rest of their lives. Now, this brings us to 1974, when Strauss et al. Conducted a study that found that the MMPI was inaccurate at screening Blacks for psychotic disorders. The MMPI stands for the Minnesota Multiphasic Personality Inventory. And this is a clinical assessment tool that was developed in the 1930s that potentially led to Blacks receiving less adequate treatment than whites due to their symptoms being less often understood. And this is significant because not only were Blacks not receiving adequate treatment, but they were left with these lifelong side effects that were associated with a medication that didn't even address their underlying mental health issue. And then we jump to 1983 to a study that was published by Mukherjee et al. And he found that of the 21 Black patients that were examined, 17 were misdiagnosed with schizophrenia and were later determined to have bipolar disorder. And this is significant because different medications are used to treat bipolar disorder and schizophrenia. Now, while there is some overlap, it has been shown that bipolar disorders that are treated with antipsychotics can exacerbate an individual's depressive symptoms. And what I mean by this is that an individual can present to the doctor with depressive symptoms and be improperly diagnosed and then put on a medication that makes their depressive symptoms worse. And so this brings me to the 1990s when the second generation antipsychotics came about. These had less side effects than the first generation. However, there were still side effects such as a granulocytosis. Now, a granulocytosis is a result of the significant lowering of an individual's white blood cell count, and it puts an individual at risk for serious infections and death due to those lowered counts. So this brings me to 1997, when Whaley conducted a study involving the Perry Paranoia Scale. And the Perry stands for Psychiatric Epidemiology Research Interview. And this scale was used to differentiate between normative and pathological paranoia symptoms. And it was found that these scales were not culture specific and may be attributed to the psychiatric misdiagnosis of Blacks. And now let's fast forward to 2019, which is the most recent study that we found that was published by Gara et al. And this was a retrospective study that found that among individuals diagnosed with schizophrenia, African Americans were 17% more likely to screen positive for depression than their white counterparts. And this is significant because this reflects the underemphasis of the relevance of mood symptoms in the diagnostic process for mental health disorders. And then after completing our research, we noticed that there was a huge shortcoming in the screening and assessment tools used to diagnose, which made us take a step back and realize that adjustments need to be made to help better diagnose patients. And this means that diagnosticians must consider race and culture rather than the symptoms for face value. And it also requires that diagnosticians recognize the implications of misdiagnoses. So when you diagnose someone with an illness, it's important to understand that that is a label that sticks with them throughout their entire healthcare journey. And that brings me to a question I would like you to keep in the back of your mind as we continue through this presentation. How can someone advocate for themselves when they are put in an environment and faced with a system that doesn't even have the proper tools in place to advocate for their best interests? And with that, I would like to pass things off to Asia. Next slide, please.
Thank you, Kara, for that. So we wanted to expand our research to better understand the mental health of those diagnosed with sickle cell. During our search, we came across studies conducted by Dr. Jonah Saint and OCEDA. We noticed a common theme in their bodies of work. People suffering from sickle cell also suffered from depression and anxiety. Multiple studies show that sickle cell warriors battle with depression and anxiety while trying to manage their sickle cell complications. This made us ask the question, why? Why are sickle cell patients suffering in silence? It can be difficult experiencing pain, but even more difficult trying to get someone to understand how badly and how often you are in pain. Not having someone to advocate for you or believe you when reporting pain can add to the feeling of being anxious. Another common theme found throughout the research and shared by Buschetta in 2020 was that low income, marital status, and unemployment increased the risk of sickle cell patients experiencing higher depression and anxiety symptoms. Buschetta's study took place from 2014 until 2019 and surveyed 97 adults living with sickle cell. This study showed that adults who had more education and married did not feel as anxious or depressed as those with less education or single. We concluded that those living with sickle cell need healthy and positive support systems in place to help promote and cope with sickle cell complications. Another study done by the great Dr. Jonah Saint compared depression severity among patients with no comorbidities to those who had sickle cell, and then African Americans with sickle cell. African Americans with sickle cell had 2 times higher rates of depression than those who had no comorbidities. The rate of depression with sickle cell and those comorbidities remained the same. During our research process, we were overwhelmed by the number of sickle cell warriors that are suffering in silence because their needs are not being met due to the implicit bias in the healthcare system. This has driven us to want to do more and be that train of change. Next slide, please.
All right. So where do we go from here? Yes? All right. So Asia, are you going to carry on? Or shall we, are you next? Go ahead.
Yes, ma'am. So I'll talk about briefly the barriers that we found in our research. Some of the barriers, I think like many of us know in this conference, that financial barriers play a huge part in seeking treatment, mental health, or even with sickle cell patients. if you don't have the money, if you don't have the resources, typically you can't get the services needed. The lack of mental health care professionals and services also are a barrier into getting the help needed. And then just the limited numbers of mental health professionals and being aware and educated are also some of the barriers that we found in our research.
All right, thank you so much.
Yes, ma'am. Thank you.
And then Ms. Fran, what did you find was happening with Black people in healthcare environments? And we're going, as I said last night, we're going to separate this. Tell me what you found in terms of disparities first.
Dr. Vic, in terms of disparities, one of the most detrimental healthcare disparities besides inadequate access to healthcare is a glomerular filtration rate equation, also known as a GFR equation. We may just think it's a number that depicts kidney function, although true, but its effect on Black patients is sinister. According to the National Kidney Foundation, the GFR equation factors in race to measure kidney function. I am sure you all have seen the lab results that depict parameters for Black and non-Black GFR ranges. Well, those ranges, which are separated by race, determine diagnosis, drug dosing, dialysis, and kidney transplant eligibility. Black patient GFR is estimated to be higher, which means the range depicts a healthier kidney function. This delays treatment and affects Black patients' eligibility to be on the kidney transplant list. Recently, National Kidney Foundation and the American Society of Nephrology formed a task force that changed the GFR equation to exclude race. This means better treatment and healthcare outcomes for Black patients, but it will take some time for hospital systems and primary care offices to adopt this new equation.
Okay, so that says a lot to me, as it did when we discussed this before. So here we're looking at a different set of standards. Now we know that there are different people and different people have different needs, and no two human beings are the same. But that disparate care for people with kidney disease, that's not just a Black concern, it is also a sickle cell concern, right? So sickle cell people also have problems with kidney function and kidney health. So it's appropriate for us to be aware and have this knowledge. Now, would you share some information with us about what you found with regard to stigmatization or stigma?
Well, with Black patients in healthcare environments, they face stigma and discrimination when navigating the healthcare system. The stigma comes from labeling or stereotyping someone. You may hear someone being labeled as a drug seeker, combative, crazy, or aggressive. Labeling causes discrimination in that it affects how you interact with the patient, which in turn causes health inequalities.
All right, thank you. Now, the communication issues. What's that? What's happening there? What did you find in your research?
Well, in 2022, Bergs and colleagues conducted a mixed method study that took place in Europe. The review included 51 sickle cell warriors over the age of 18 that identified as Caribbean, of African descent, or African. Sickle cell warriors in this study explained that they were not able to openly voice their needs. They feared retaliation from medical personnel, like delayed pain medication administration, or being labeled aggressive when questioning medical decisions or treatment. In this case, communication was non-existent. They remained quiet, or as the study puts it, agreeable. They would not, so they would not agitate healthcare providers. They were not able to express how they wanted to receive care or what worked for them in the past. They were meant to be seen and not heard. They were meant to receive what was given without question. Now think about the psychological toll this has on a person. Now think about going to the same institution for help time and time and again. Lastly, think about how that makes you feel and amplify it.
All right. So now, let's go to Miss Chelsea. And tell me what your thoughts are about how we might be able to decrease the stigma associated with mental illness. And I know, I'm just going to go ahead and say it. They've already told me that's the $1 million question. And from our talks earlier today, we know that this is a heavy, heavy issue and a heavy load. But Chelsea, just share with us what your thoughts are about it, please.
Well, as Dr. Vic stated, it's the $1 million question that we ourselves are still searching for. And we don't really have the best answer to it, but I guess there are some things and some ways that can be done to change and decrease the stigma. So creating and cultivating a truly safe space and environment for our patients to be authentically themselves. This means having providers that look like them, not rushing our patients when we're speaking with them, and having honest, non-judgmental, and transparent conversations about their treatment and care. This also means normalizing mental health and recognizing that different communities treat the concept of mental health differently, and that we should tailor our care to acknowledge that. Asking patients, what do they want out of their care? What is your goal? How can I better serve you on your journey? Healthcare should be a collaboration, really.
Indeed. Oh, that's awesome. This is what brings me joy, because I know that you're coming into this profession, and I'm so grateful. All right, share with us what you found that you believe will help you to prepare to practice as a nurse. And I'm gonna start with Chelsea, but I want everybody to put their feedback into that. So Chelsea, please tell me, how is the work that you did in developing this project and coming to this point in time, how has this helped you to prepare to practice as a nurse?
Well, I think the first thing is that it's helped me to really listen and observe and leave my bias at the door. Honestly, we're all human and we all have our certain biases, but as future healthcare professionals, it would be imperative for us to check ourselves. We should be mindful that our patients deserve respect, have rights, and their own wants and needs. Our research has allowed us to understand that the patients we encounter are people. Healthcare can be a stressful field, and burnout is real for nurses. And this can cause people to lose their empathy and compassion in a way. But we just have to remember that our patients deserve respect and individualized care. No one patient is the same, and it is important to understand that all treatments and care should not be the same for them. Our work has allowed us to refocus and understand that our duties as future nurses go beyond just treating symptoms, but patients. These are human beings, and we have to advocate for them. We are reminded that our actions must be reflective of what they want and what they need. It's not about what we think is best, but what is best for them. They may have a different vision or outcome for their treatment, and collaborating with patients and removing that I know best attitude when addressing them.
Thank you so much. Asia, will you go next?
Yes, ma'am. So I agree everything what Chelsea said. And Dr. Vic, I want to first thank you for just allowing us to be able to do this project, because I don't know if I would have gotten as much as I did out of this project from my clinical experience. You've allowed me to see that I do have biases as well. I go in and we kind of get presented with this perfect environment in clinical or in simulation, and you don't realize that there are real people facing real things out here because of our bias. And this project just reminded me that I too have biases, and I need to check those. And like Chelsea said, I need to leave those at home. So this project has allowed me to realize that the people that I am treating are more than just what is found on a piece of paper when I read their chart, that they are actual people and they actually need help. And I have to go above and beyond, because it sounds good when you well, I'm here to help, but am I really helping? So just being a part of this project, being in your class, meeting you has really helped me realize that, just because I show up does not mean I'm helping. And I can do more. And this has prepared me to allow me to know that I can do more, and what more am I doing? And every day is a learning opportunity for me. And am I learning? So if I go home and I decide that I didn't learn today, then I didn't do my job. I didn't help. I can take 1 second and say, how are you feeling today? And just doing this project has allowed me to realize that I wasn't doing that. And I think now, after going through this experience, I believe I am more prepared to be the advocate that I am supposed to be now, because I now understand that there's so much more in healthcare that I can do instead of giving meds or reading a piece of paper. I can do so much more that they don't teach you in nursing school, but just being a part of this experience has taught me. So I do appreciate that.
Thank you. My goodness. You've given us a lot to think about. Miss Carol, will you tell us what your thoughts are? How this has helped to prepare you for your practice as a nurse?
Yes. So piggybacking off of what Asia and what Chelsea said, this project has allowed me to do a lot of self-reflection. It's often so easy to point the finger at everybody else, point the finger at the system, et cetera, but not often do we point the finger at ourselves and ask what we can do to better ourselves and to be a better advocate for our patients. And throughout my entire nursing experience, we constantly talk about safety. Safety, keep patients safe, but we never really talk about what that truly looks like, what a safe space truly looks like. And I think it's important to understand that a safe space can look different for everybody. What makes me feel safe might not make the next person feel safe. And I have to take into consideration that, people come from different backgrounds, different religions, they have different beliefs, and it's important to incorporate those beliefs in their care so that they can receive the best care possible. And this project just really, I don't know, it just really gets me all excited about the possibility of change and the change that can occur in the future and the steps that we can take going forward. I mean, we still have a long way to go, but I feel honored to work alongside these girls and to work alongside you to try to make a change, because going into nursing, that's what my goal was to make a difference, to make a change. And I feel blessed to be able to work alongside you guys and be a part of that process.
We feel the same way. Miss Fran, please share what your thoughts are.
Well, Dr. Vic, I think everybody summed up everything that I was thinking. The running theme here is start with yourself. It's all about you, because that's going to affect how you provide care to your patients. And then another thing, I just want you to challenge yourself, especially doing research. Recognize things that you have a lack of awareness of and challenge your beliefs. Ask yourself, where did I hear this from? And is it fact-based? How does what I believe affect my patients? Am I really acting in the interest of my patients, or am I doing what's comfortable for me? Because a lot of the times these patient interactions might be about us. We might be doing some projecting that we have no business doing, or something like that. So that's just my little tidbit, what I want to add. And thank you again for this opportunity to speak at this conference and for being in your class. It's definitely been a blessing. And I agree with Asia. It definitely gave us an opportunity to kind of take a look at ourselves.
Wonderful, wonderful. I thank you all. Looks like we do have some questions in this chat. So shall we go to questions? I'm talking to the coordinators here, or do we have time? Do I have time for one more question for the students?
You have time for one more question.
Wonderful, wonderful. Okay, so my final question is, and I'll start with Chelsea here. What can we do to improve chronic disease outcomes, such as sickle cell disease, when they have a comorbid sickle cell disease and a mental health diagnosis? So what are your thoughts about that?
I think that it's important for healthcare providers and professionals to educate themselves and to look for mental health symptoms in patients and recognize that different cultures and communities present differently, and ask questions. And also, we must hold providers and ourselves accountable to ensure we are doing what is best for our patients. If a patient does not want something or does not feel that they don't want to participate in something, let's ask questions. Let's see, why do you feel that way? How can I help you? How can we come to a collaboration? And then lastly, I think one of the most important things and one of the first things we learned in nursing school was that a patient's pain is what they say it is, and it is not for us to decide that it is not. And in sickle cell disease, pain is a huge factor. And it is especially essential in understanding our patients and what we can do for them. And this will be helping us adhere to what they want and what they need. So just creating a space that providers and professionals will be listening to what their patients want and need. And also this will help develop trust between healthcare professionals and the patient.
Mhm, mhm. That trust aspect is a huge thing. Very, very important. Thank you so much for bringing it up. Asia, is there something more that you would like to add in terms of what can we do to improve chronic disease outcomes in patients that have sickle cell disease and perhaps comorbid mental health?
Yes, ma'am. So I do believe that we must first educate. I think we always stress the importance of education. We also have to be aware of those missed opportunities. Like Chelsea said, like we have to catch people like even when they're coming in for a checkup, just catch them in a sense like you're just asking, how are you doing? And truly mean like, how are you doing? Because a lot of times we see that sickle cell patients and other people suffer in silence because there isn't any trust, or we have those missed opportunities where we can build rapport and build trust. So just catching those missed opportunities during a checkup. We're checking on your pain. What's your pain? If your pain's 7 out of 10, okay, well, when we get the pain down, let's see, well, how are you doing now? Like, how are you truly doing outside of your pain? How are you feeling? And like really getting those times to even, do a quick depression scale to just see depression screening to see how that person is actually doing, because there's a lot of times when we just miss opportunities and these people are suffering in silence and they don't have to, like they really don't have to, because like we aren't doing our job to reach out. It's already overwhelming that they're dealing with their complications and their mental illness or their pain. So it's just really important that we go above and beyond and seek help from them. Like, how can we help you? And just like building that relationship. So I think that's one way. And I mean, like it's been stressed throughout this presentation, it's really an individual thing. We start on an individual level. How can I better myself so then I can be better for somebody else? Because if I'm not doing well, then I can't pour into somebody else if I'm not being the best person. So just individually educating ourselves on like, how can we find those missed opportunities in doing that? So if someone sees me just taking that time out to do a quick screening to see how my patients are doing, maybe my colleague could do the same thing next time when she or he meets their patients. And then that can just start like a universal thing that where people are following that and catching those opportunities, so people don't have to suffer in silence.
Thank you.
Yes, ma'am. Thank you.
Frenesia, will you share any final thoughts on this topic?
You're muted. You might want to go to Cara.
Okay. Miss Kara, would you share?
Yes. I mean, I think that Chelsea and Asia summed that up pretty well. But I also think it's important to know that we have very limited opportunities build trust because of where we're starting our baseline at with African American patients, especially considering the hundreds of years of mistrust that we have in the medical system. And we might only have one opportunity, right? So someone could present to the hospital in pain and their expectations might already be like super low. And if we don't capitalize off of that opportunity right then, we might prevent a patient from wanting to come back and get treatment. Therefore, now we're having patients that are suffering alone, suffering in silence, suffering at home, when we have the resources to be able to address their concerns and any issues that they may have. So I think the biggest takeaway is to realize that the small opportunities are just as big as the really big ones. Just a regular ER visit is just as important as the first time as it is the fifth time for these patients.
Thank you. Thank you so much.
I just want to say, this is the first time we've had students. You all are so impressive. We talk about the need to mentor the next generation. I look back on my 20-year-old self, and I don't think I was nearly as mature as you all are. And so all the comments are just phenomenal. And they wish you the best and state it's an excellent presentation. And you all did a phenomenal job. And thank you for sharing. And I'm so happy that that nurses of your caliber will be coming into the workforce and helping the next generation. So thank you all for agreeing to present.
I'm with you.
Yes,
I
ma'am, and thank you. Yes, we appreciate the opportunity as well. And thank you, Dr. Vic, for just allowing us to speak and giving us the opportunity to come here and speak in front of this panel.
thank you all very much. We really appreciate you. We're in good hands. I know that.
So we can head over to our next session. Thank you all so much again. I could have honestly listened to you all day. You did an excellent job, and your hearts are all in the right places. So thank you.